Can you see my slides, please, Jeremy?
Yes, beautiful. Thank you.
Okay, great. Thank you so much. Thank you, Dr. Cheng. Thank you, Dr. Lau, for kind words. And at the onset, I would just like to thank you all for giving me this opportunity. And Jeremy, I want to just make a point that in case I'm running out of time, kindly let me know, interrupt me in between, so that as Dr. Cheng said, we have to close it in time, so we should be on time. Okay, please, I'm giving you the liberty to do that, please, and help me out.
Yes, madam.
Yeah, okay. Daniel gave an excellent presentation on ICT algorithms. My topic for discussion today is totally different. It is on CRT, the basic ECGs of CRT and the troubleshooting we can do with them. So if you can see my slide, the right side of my slide says a perfect ECG. This is what we love, a beautiful sinus rhythm, a narrow QRS, 1:1 conduction. And this is what we are aiming at patients when they show a wide QRS of an LBBB, left bundle branch block. We try to narrow it down so that it looks as perfect ECG as possible. But remember, CRT is an electrical solution of an electrical problem. This is what is seen on the ECG. It is an electrical problem and we are trying to give it an electrical solution. And the QRS morphology and duration, it is determined by the stimulation sites. That means where we are going to put in the leads, specifically in the RV and in the LV. And how are we adjusting the AV and VV delays in the patient, making them an individual for that particular patient. We have to individualize the programming for every patient. And slides are not going forward. Okay, so if we look at the data that we have, the patients who have a left bundle branch block, in all the ICT trials, the randomized controlled trials and the meta-analysis of that data shows that patients with left bundle branch block actually fare badly as compared to the other bundle branch block, the right bundle or the IBCD pattern. And if we adjust this to the CRTD arm, well, the patients with left bundle branch block, the nicely selected patients do very well and they have a mortality benefit with these. This mortality benefit is not passed on to the patients with IBCD and right bundle branch block. And if we look at the analysis of the data, we see that all left bundle branch block patients, the women fare much better than the men, and the wider the QRS, the more benefit is transferred to these patients. However, in non-LBBB patient, this benefit is not transferred except for the patients who have a wide QRS, which is more than 150 milliseconds. Henceforth, the super responders are actually females with non-ischemic cardiomyopathy, wider QRS, and left bundle branch block. But the narrower the QRS, the IVCD pattern or the non-left bundle branch block pattern that we say, the benefit is not transferred to them. Hence, we have the guidelines looking into all the data that we have. And this is a class 1 indication that QRS more than 150 milliseconds, left bundle branch block, LV ejection fraction less than 35%, who is symptomatic despite guideline mediated medical therapy, they become the class 1 receivers of CRT therapy. However, CRT therapy is a class 2 indications in non-LBBB patient with the rest of the parameters remaining the same. In between 130 to 150 milliseconds, it becomes a class 1 indication in case the LBBB left bundle branch block QRS pattern is there, but the level of evidence is B. It is not A, it is B. So similarly, in case the QRS width is between 130 and 150, in a non-LBBB patient, it's a class 2B indication. The class 3 indication or a contraindication, which I should say, is a QRS duration less than 130 milliseconds. This is very clear and there is no doubt about it. Now, if we look at the ECG here, this is a 60-year-old female with non-ischemic cardiomyopathy, ejection fraction 30%, and symptomatic with NYHA class 3 despite medical therapy. Look at the ECG. Do you think you would recommend a CRT? Patrick, can I have the poll here, please? So is the 10-second over? Then we can have the result. Okay, so most of us believe that it is not the CRT is not recommended in this patient. What about if this patient has this ECG? Kindly give the poll again. What about if this ECG is there? Please, may I see the result, please? Yeah, so everybody thinks this is recommended, and that is a beautiful answer, because you see here the criterias are fulfilled. The QRS is wide, it is 150 millisecond, it is left bundle branch block, and it is though there are some notching there which we will just discuss, it is the indication for a CRT and a good result for that. Now, we have had a lot of trials and the guidelines which have studied the various criterias to recognize left bundle branch block from the ECG and give them in correlation with the CRT outcome in these patients. The most important thing which I want to discuss here is the mid QRS notch that we have been discussing. And if you see the Strauss criteria for the mid QRS notch, the slurring in more than 2 leads from V1 to V2 or lead 1, V5, V6, the mid QRS notch has a very high sensitivity rate up to 94% to be correlated to left bundle branch block who will benefit from CRT. Now, if we look at this ECG, please see that the QRS is wide. It is more than 120. If I can measure it rightly, it is around 150 milliseconds. It's a PR interval is okay. It's normal, and you see the notches. Just look at the notches. I've put the markers here for the convenience of everybody. The QRS width is 150 milliseconds. You see there is absence of Q waves in lead 1, V5, V6. There is a mid QRS notching which is seen in lead 3, in lead V6. So even in lead 1, 1 and AVL. So this is the kind of pattern you look at in the ECG to advise CRT in these patients, and they will definitely benefit. Let us look at what happens post implant also. So these are just summarizing the factors which we have to look at the ECG before recommending a CRT device to the patient. We have to look at the QRS width, QRS morphology, some notching according to the Strauss criteria, and certain miscellaneous features like fragmented QRS, like RS in V1 being more than 45 milliseconds, delayed intrinsic deflection in lateral leads, and a PR interval which may be prolonged. Now, what is the role of ECG post-CRT? Once we do the CRT, we use ECG to monitor the follow-up of the patient. We ensure good LV capture. We look at leads 1, 3, and V1. And we should be aware to look at the LV latency and anodal capture. We'll discuss about this in the subsequent slides. The detection of arrhythmia has to be seen, whether the patient is in atrial fibrillation or patient is in having frequent VPCs. You have to look at the narrowing of the QRS and optimizing the delays. The V1 has to be positive, which ensures the LV force is more than the RV force. Lead 1 is negative. That ensures that the lateral part of the LV is activated first. So there is no shortcoming to selecting a good vein and placing your lead in the posterolateral or the lateral branch of the coronary sinus. If you do a good job at the time of implant, the ECG will result into a good outcome. There will be a good, the electrical problem will be dealt with a good outcome on the ECG. So you have to look at it. Sometimes we cannot, do not cannulate the posterolateral vein, and we go in for this middle cardiac vein and go, in fact, away more apical or towards the septum. I will just show you the examples where it doesn't help. So please look at a good target vein to give a good result of CRT. When we are looking at the ECG with biventricular pacing, we have to be sure where our RV lead is, because many of us are putting our RV lead in the right ventricular outflow tract. Earlier, we used to put it at the apex, whereby we used to have the 2-3 AVF negative and We used to have V5, V6 negative because it used to be from the RV apex. But many of times the lead is placed in the RVOT, whereby we have 2,3 AVF, which is positive, like VPC coming from the RVOT, the similar complex it will have. And we can have, because of the placement of the lead, in case it is very distal in the RVOT, we can have lead V1 positive in these cases. So dominance of R wave in lead 1 is very important in the post biventricular pacemaker ECG. And in case the RV lead is at the apex. So this has been labeled as a positive response by Swinney et al. And the relationship between the presence and the amplitude of the paced R wave in V1 has been related to the best mechanical and hemodynamic response. In case there is no dominance of R wave in V1, we have to look at various parameters, whether there is an incorrect placement of V1, whether there is lack of capture of the LV lead, whether there is a displacement of the LV lead, whether there is marked LV latency, there is a ventricular fusion, or the pacing is from the middle cardiac or the anterior vein. We'll just discuss it in detail. And these two leads are actually the most important leads which we have to look at. In case we find lead V1 is all positive, it is all positive, then it is the LV pacing. In case it is biphasic, then it is the bi-V pacing. If the lead V1 is biphasic, then it is true bi-V pacing. But lead 1 altogether has to be negative because the free wall of the LV has to get activated the earliest. So when we are looking at the LV right versus left ventricular capture, for the left ventricular capture has to be a positive V1 and negative lead 1. But if you have lead 3, which is more negative than lead 2, then right is activated more than left. Please keep a note on that. But if you have it in a good posterolateral vein, this is how your ECG would look like. Your V1 will be positive or a biphasic. The lead 1 will be negative. And you look at this, 2,3 AVF is negative, but look at lead 2 being more negative than lead 3, which means that it is the left-sided which is activated early. In case there are certain sites in the LV which we sometimes choose to pace in case we have a middle cardiac vein, well, you are in the middle cardiac vein, your V1 will be positive, your lead 2,3 AVF will be negative, but look at lead 1. You look at lead 1, this is positive. Whatever you do to do the programming in these leads, in case your lead 1 is positive, then it is you have to reposition your lead and there is no second thought about it. This is not a good decision to leave the patient here. In case the lead is in the anterior vein, then you have placed it towards the septum. You have gone in the anterior vein. Instead of going on the lateral side, you have gone towards the septum. And when you are towards the septum, what will you will have in the ECG is actually 2,3 AVF being positive, lead 1 is positive. Even if you have V1 which is biphasic, there is an initial positive response. There cannot be a bad position for this patient, and it is recommended that instead of aiming for electronic repositioning, you should replace the lead to a better path. Sometimes what happens is that we are doing the LV threshold. You see this ECG showing you the LV threshold we are doing. You can see a different variation of the QRS. Well, the lead position is the same, but as you are doing pacing at the different output, the vector becomes different. How do you explain that? How do you explain this? The only way to explain this is probably a nodal stimulation. A nodal stimulation occurs because of the hyperpolarization of the cell, which causes the wavefront instead of depolarization, and it is a large anodal area which causes this to happen. Most of the time, the LV lead has been programmed in the pseudo bipolar mode that we call it. So here the threshold of the LV will be okay, but V1, the lead 1 will be positive. So what we can do here is to switch the LV lead into a bipolar rather than pacing between the LV lead as the cathode and RV as the anode. And this was true in the older devices. With the third generation of devices that we have as of today, this problem has been taken care of. But in the older devices, we may still see this problem. Hence, I have brought this here to take care of it. Now, when we see the ECG, we can also localize where we are pacing in the LV. In case we are more basal, which is the preferred position, then the forces from V1 to V6 will be positive. But in case we are apical, the forces will become negative in V5 to V6, thereby telling us that the LV lead is actually more apical than basal. We have to look at the QRS width response post CRT, and it has been correlated with clinical improvement. The QRS width goes down, that has been correlated with hemodynamics becoming better. But here, a word of caution that in case you have a very wide QRS, even when you connect the device and make the QRS to be narrowed, the QRS becomes narrow, but the dysynchrony is not gone. It is because of the electromechanical delay, which occurs especially in the ischemic myocardium patients, whereby the narrowing QRS does not clear off the dysynchrony in all the segments. So what is the outcome here? How can we help these patients here? The most important factor to do here is to look at the fusion vector, which I'm just going to explain you what is the fusion vector. See these leads, we are pacing from the RV lead alone. We are looking at the complex in lead 1 and in V1. We are pacing from the LV lead, which is close to the scar. And here, what we are doing is that we are having, this is the lead 1 and this is V1. When we pace biventricular simultaneously, we have to look at the lead 1, whether it is looking like either of the two, either RV or LV, or it is a fusion between the two. If it is looking like one of them, then the LV lead is actually having struggle with the scar. There is a scarred area there, which is causing the dysynchronous activation of the myocardium. And what we need is the synchronous recruitment of the myocardium. So what can we do here? What we do here is that we pace the LV early. In case we pace the LV early, then we get the complex, which is in between the RV and LV pacing alone. And this is a good result. We are able to actually obscure the scar, which is close to the LV lead, and give patient a better result because of this vector fusion. Example of a ECG which we sometimes see, somebody tells us that this is biV pacing going on, and we look at the ECG and we see that V1 is totally negative, lead 1 is positive. What do we do here? Well, this is not good biV pacing. We have to start thinking in terms of whether the LV lead is not working, or is there too much of delay at the LV site, or there is some anodal stimulation. And if you look at this rhythm strips, there is variation. The vector is changing here. How can that be possible? Look at the PR interval. The PR interval is very short. So probably increasing the delay here if we lengthen the AV, that will help us. So in such patients, in fact, adding a medical therapy or stabilizing the dosage of beta blockers might help us to help such patients. If we see the ECG like this, there are another example of biventricular pacing. Look at V1. The V1 is all positive. If it is all positive, it is pacing the LV. 2,3 AVF is negative, which is good. But look at lead 1. Lead 1 is again positive. This has to be middle cardiac vein. And middle cardiac vein, you have to, until and unless it's a really lateral site in the middle cardiac vein where you can place it, you cannot correct this thing. And a word of suggestion here is that when you are doing a biventricular pacing on the table, the most important lead that you can hook up to give you a better result is actually lead 1. You hook up lead 1 and you see whether the lead 1 is converting into a negative or a positive when you pace the LV, and that gives you the answer there and then. You may have a post biventricular pacemaker ECG, which is like this. You have given a good result. The lead V1 is bipolar. There is an initial positive complex and then negative. Lead 1 is negative. But look at the ventricular ectopic activity. These are monomorphic ventriculars, VPCs, which are coming in between quite frequently. This will not let the biventricular pacing to be at the extent of more than 95%, which we are aiming at. So it is better to take care of these ectopics, do a RFA, and just get rid of these ectopics or stabilize the medical therapy, which is very important to give a good result in these patients. A word about the frontal axis. This is, I brought it here because it is important for us to understand that with the changing technology and the recent advances in the algorithms occurring, there is some changing in the thinking which is coming here. Initially, we thought we were pacing in the RV apex, where we used to get the axis, which was left superior axis. Now, with the CRT and right ventricular apical pacing, the axis changes to right superior quadrant, because this is where it is supposed to be. Now, more and more pacing is being done in the right ventricular outflow tract. Hence, once we have either a CRT with RVOT or LV pacing alone with the RVOT pacing, the shift is occurring towards the right inferior quadrant. So it is important to know that this shift of axis is actually because we have changed the placement of the leads and the algorithms that we are working up, which are working towards the fusion of the QRS rather than only the standard CRT that we used to have in the first and the second generation. The positive in lead B1, whether it is completely positive or biphasic complex, it is related and it is positively related to the responder rate. However, the negative in V1 results into non-responders. We have enough data to substantially support that. So to summarize all this in a table, this table I'll just briefly discuss that if you have a dominant R in V1, it is a LV activation, which is good. But in case you have a RS or the QS pattern in V1, you have to look at various modalities to see why it is happening that there is no R in V1. And you may do the programming again, programming in form of VB programming. You may pace the LV first to try to have the dominance of the R wave in V1, or try to look at what is the reason for not having a prominent R in V1. A word about the latency and the slow conduction of the wavefront that we so commonly talk about. Now, in case we have a biventricular activation, both LV and RV forces are equally equal. We are pacing both of them at the same time, but LV is the force that we require, the myocardium that we require to pace first. So the biventricular activation time is good. But in case of latency occurs very commonly with LV pacing. It is from the pace stimulus to the initiation of the paced QRS. The time period that is taken is the latency, which occurs more with LV pacing than RV pacing, which is because of the LV pacing being done from the coronary sinus vein. It is the indirect stimulation which occurs, and there is a long distance of the electrode to the subendocardial hiss. The sequence of activation is from the epicardium to endocardium, so there is prolonged refractiveness, hence resulting into latency. So if there is a presence of latency or there is a slow conduction because of the scar, for both these things, you know, when we pace, the biventricular activation actually occurs from the RV. The depolarization starts from the RV, and that is the stronger vector than the LV. And this needs to be taken care of. Now, how can we take care of it? We have to take care of it by doing the playing with the VV delay. In case we pace the LV first, it is able to take care of the latency part, and the biventricular activation time improves. And in case we do only LV pacing, fusing it to the RV sensing, then this fusion complex or the fusion with the spontaneous QRS takes care of the latency. This is what is important, and this is what is the basis of the latest algorithms that we see in the generation 3 devices of CRT. This is the conventional biventricular pacing, whereby we program a shorter AV delay, and the native activation is replaced by a extreme axis with a pacing both from the LV and the RV, and the QRS looking in the ECG with positive V1 and negative lead 1 and extreme axis that we have just discussed. But now if we are looking at the fusion CRT, well, fusion CRT, there is a simultaneous pacing from the LV and RV along with the intrinsic conduction. The intrinsic conduction is there, and there is a fusion complex resulting in the ECG, which I'm just showing you. The QRS is narrower. There is a biphasic complex in the V1, which means it's true bi-V pacing and not only LV pacing, and lead 1 is negative, but the axis changes. The axis becomes, instead of extreme axis, it becomes the right axis. And then we are talking more and more about the LV pacing alone in conjunction with the RV sensing. This is what happens when we are sensing from the right bundle and we are pacing the LV. The QRS becomes narrow and it is as close to normal as possible, which we are aiming at. So I will just discuss a couple of examples with you whereby we have done the programming and made the patient's parameters better. This is the ECG. You are seeing the baseline ECG of the patient. If you see, the QRS width is around 140 milliseconds. There is some notching on lead 1 and even on lead V5, V6. The PR interval is short and it is normal. So this patient was given a biventricular pacemaker. Hereby, the patient is pacing from P3, which is the longest QLV which we got, and the AV delay was the nominal of 120, and we paced at the default of LV 40 milliseconds before RV. And if you look at V1, it's a beautiful positive V1. All the forces are towards the left. The lead 1 is negative. But what do we have here? What we have is a wide QRS. The QRS width is still 180 milliseconds. What can we do to narrow down the QRS to have a better result? Because the forces here are totally from the left. They are left-paced activation. What we do is that we make it less early. We reduce the LV first to 10 milliseconds before RV, and we have a better QRS. It is narrower. Lead 1 is still positive, lead V1 is still positive, lead 1 is negative, and this is better. So this is a standardized traditional CRT pacing that we get. Can we do more about it? Well, what we have done is we have added sync AV delta. Since the PR was short, we have added a minus 40 milliseconds of sync AV delta to the programming. And look how narrow the QRS has become. There is still a positive hump in the V1, which means a bi-V pacing. The lead 1 is biphasic, but it is a beautiful result, which has been obtained first by adjusting the VV delay, making it less early, and then by adjusting the AV delay by sync AV delta. Sync AV delta has been bi-V with sync AV optimization has been studied in various in trials, and it has been analyzed that to have given the best possible result as compared to the other algorithms which have been studied in the biventricular pacing. And then fusion optimized intervals are actually have also been studied in cardiac resynchronization therapy. It has been seen to be giving the narrowest QRS possible by the fusion optimized intervals, which has resulted into reverse remodeling of the QRS, thus giving a better outcome and better ejection fraction in these groups where fusion optimized algorithm is used. Giving another example of how important these algorithms are. This is the baseline ECG of a patient showing a left bundle branch block. QRS is around 150 milliseconds. There is some notching attached. PR is around 200 milliseconds. It's a left bundle branch block pattern. And the patient was given a CRT device. We achieved V1 to be positive. We achieved a lead 1 to be negative, which is very beautiful. And a standard AV delay was programmed to 90 and 110 milliseconds as per the device default. The QRS is good, the results look good, but if you look at lead 2, there is a notch present right in the beginning of the QRS. There is a notch which actually is not a good indication. So we played with the sync AV delta. We made sync AV delta 10 milliseconds and we lost the positive R in V1. But look at the notch in lead 2, it has become delayed. So we went further to make it to 20 milliseconds. The lead V1 still remains the same, but look at the notch in lead 2. It is getting more delayed. That means this notch, which is indicative of a scar, is actually getting delayed. So went ahead with sync AV delta at 30 milliseconds. And if you see, there is a slight hump appearing here in V1, whereby a very slight hump is coming. But look at the notch in lead 2. It is becoming more delayed. It is getting at the end of the QRS. And at 40 milliseconds, as I've highlighted, look at the notch. The notch has actually gone to the terminal end of the QRS. And in lead V1, there is a positive. It is a biphasic V1 which has come in, which is actually very beautiful. And the PR has become normal. It's 200 milliseconds. It has become normal. And the ECG looks so beautiful. It is a narrow QRS. You cannot have a more narrower QRS than this, I think. And the notch in lead 2 is just out of the QRS. It's a biphasic V1 with a very good results on hemodynamics. So sync AV actually works very nicely. You have to individualize with the patients. It works very nicely to help the patient. In case, what is standardly practiced by us is that we play with the sync AV first. We try to give the best result doing the sync AV. And in case we are not able to, or we are, there is some lacuna still remaining, then we adjust the VV delay to either making it simultaneous or LV first. And then we get the results, we try to get the results of a narrower QRS and a good ECG representation in lead 1 and V1. Here I want to add a point that, we have to keep these patients on a regular device optimization follow-up because, once they start exercising, whatever work we have done to place the AV delay and VV delays there, it gets changed with exercise. So dynamic AV delays are very important. And in addition to that, once the patient starts to have reverse remodeling, whatever you have programmed 6 months ago does not count. So you have to keep these patients on a regular follow-up so that you can change the parameters as and when it comes and give these patients a better outcome. So looking at all these parameters which we just discussed, we have to follow this table to give benefit to the patient. Is AV conduction intact? We have to ask ourselves, we have to see the ECG and we have to adjust the VV or the VV delay or sync AV. Is dynamic AV programmable available? If not, then we have to do it as a short AV interval to give 100% by V pacing, and we have to optimize the VV delay. And then we have to follow up these patients on a regular basis for the device setup. But whatever we do here, the most important thing to have a good responder is that we put the lead in a good position to start with so that we are able to salvage the situation. Otherwise, nothing we do later on after putting the lead in a suboptimal position is going to save the day. And we have to avoid any extreme programmings, and because extreme programmings, they never correct. We have to stick by the guidelines and follow them one step at a time to give a good outcome to the patient. So to summarize, 12-lead ECG provides important information for the clinical follow-up in CRT, but needs to be carefully evaluated. AV and VV delays need to be optimized on regular basis using the device algorithms and office follow-ups. Echo optimization, I don't do it anymore because we have such good algorithms available in the devices, but it can be reserved for patients who are the non-responders. RV only or LV only pacing should be performed for better understanding of the ECG during follow-up. We have to do serial ECGs and try to do the optimization and the troubleshooting by doing this. And LV pacing alone can be as effective as IV pacing, but it has to be done in patients who have normal AV conduction. And we have to time it well with the intrinsic activation of the patient. So to get a good result, we have to know not only to do a good CRT, but to program the CRT in a correct way so that we get a good outcome on the ECG. I have a couple of ECGs here to show. Jeremy, was that you?
Hi, this is Jeremy.
Yeah, was that an indication? I heard some noise. I kind of a
Not
button.
from me.
Okay, so can we show these 3 ECGs as the quiz time for everybody? Do we have time for that?
Yes, please.
Okay, great. So this is the first ECG. Can I have the questions up here, please? Okay, so would you recommend CRT for this patient? I have just given 10 seconds time because either you know it or you don't know it. So 10 seconds should be good. Okay, perfect. So everybody agrees that this patient needs a CRT. I'm so happy. Okay. So as we discussed, the QRS width is around 150 milliseconds and there is a mid QRS notching in lead V1, AVL, and V5, V6. So this patient is going to be a good candidate for CRT. Now this ECG, can we have the question on, does this patient need a CRT? Okay, can we have the answer here, please? Yes, exactly. So that's very good because this patient does not have a typical left bundle branch block. Patient has an IVCD, though the QRS is wide, up to about 140 milliseconds, but still he fits into a class 2B indication of a CRT. So that should not be the first line of interest for this patient. Okay, can I have the question here, please? Patrick, please. I think the question is wrong. The question is that, what do you think is the pacing here? Is it a good pacing? I think the question is wrong. So you can just answer whether, do you think it is a true CRT pacing, true BIV pacing? Let that be the question which you have to answer. Okay, if you have the answers, otherwise I'll show the answer, of course. So it is a true BIV pacing. If you look at lead V1, it is positive, or I can say it is biphasic, and lead 1 is negative, and we have a narrowing of the QRS to about 100 milliseconds. So it is a very beautiful BIV pacing that is there. You can play around with the notch as we just discussed. With the sync AV, you can play around with the notch to have this notch eliminated from lead to the center of the QRS or the QRS distally. That's all. Thank you so much for your patience and for having me here. I hope I finished in time, and if there are any questions, I will be very happy to take them.
Thank you very much for your presentation, Dr. Aroa. So let's take a few minutes to answer. There's quite a number of questions in the chat box, and let's do. This is the first questions. What about intermittent LBBB with prolonged duration? Is it a CRT indicated?
That's a very good question. This field is still not very clear whether intermittent left bundle branch block will benefit from CRT. There is no substantial data available. But as I have discussed with a couple of people, what they think is that this patient will ultimately have a delay which is there. There is intramyocardial delay which is occurring. So people have started giving these patients the advantage of CRT, even in case they are symptomatic despite medical therapy, in case the ejection fraction is low. Yes, then these patients are being given CRT. That's what I know of. Is Dr. Ching there with us? Maybe he can help
Hey,
me
hi,
out
Prof.
here.
Ching.
Hi, Dr. Ching.
Hi. Thank you for the wonderful presentation.
Thank you so much, Dr. Ching. I want your help to answer this question. I really don't have the data about it, but about intermittent left bundle branch block with prolonged duration. Is CRT indicated? Are you doing for intermittent CRT?
Okay, so number one, at what rate does a patient develop a rate-dependent left bundle branch block? If it's a low rate, for example, he goes into a left bundle branch block at sinus rate of 70 or 80, and he has an ICD indication, then I will veer towards a CRT. If he goes into a rate-related left bundle branch at high rates, 120, 130, then I am not inclined to put a CRT. Let me tell you why. Nothing beats intrinsic narrow QRS. You can't synchronize a heart any better if the patient has intrinsic narrow QRS. And if we put a CRT in this patient, and we are compelled to biventrically pace, we are creating an artificially wide QRS. We can't beat the intrinsic QRS. So that's my position. So a difficult question to answer, but these are pointers towards CRT versus an ICD for such patients.
That's what I also thought. We don't have data on this topic, but this is a very interesting topic. There is a lot of data, in the patients who develop left bundle branch block and have a chest pain. They develop intermittent left bundle branch block and have a chest pain, which is mimics that of angina. People are doing left bundle branch block pacing in those patients. I don't know. There is no randomized data on this, but that sounds very interesting. That really sounds very interesting to look into that area.
Right. Thank you. Thank you, Prof. Cheng, and thank you, Dr. Arora. Here's another question. It's a male, 54 years old, with non-ischemic dilated cardiomyopathy, recurrent VT, EF 30%, ECG January 2020, show LBBP QRSD duration 150, but declined CRT implantation. So he had progressions of heart failure and VT, but the ECG changed to RBBP and AV block 1. Will the patient respond well if we implanted a CRT-P? Would you have any comments?
This is a very interesting situation. So the patient is a 54-year-old male, a non-ischemic cardiomyopathy, ejection fraction is 30%, is having a recurrent VT, and has from left bundle branch block now developed right bundle branch block. So he has alternative bundle branch blocks which are involved. And now he's again symptomatic with progressive heart failure. Well, if he has a documentation of a left bundle branch block earlier and now has developed right bundle branch block with first degree AV block, as I can understand. I think implanting this patient CRT-P is a good idea because his both bundles are diseased. He's having alternative bundle branch block, and then giving him a fusion complex to narrow his QRS will be a good option, and this patient should benefit from the CRT implantation. This right bundle branch block may have come because he must have been given some medical therapy because of recurrent VT that he's having. Amiodarone is the most culprit drug which is given in such patients. So maybe he has developed, because of that, he has developed the right bundle branch block now. I don't know the details, but that's what I can think of.
Yeah, so I think very interesting case. It's a person with low EF and VT. So with that in mind, I think we probably can't avoid an ICD, a low EF and ICD, low EF and VT. The next question is to decide whether just a single chamber ICD or a dual chamber or a CRTD. And rightfully pointed out, that with medication, the axis may change. So he may not really have a true left bundle branch block. He may have conduction delay in the left bundle branch. And with progression of disease, or due to side effects of amiodarone, the conduction in the right bundle slows further, and it becomes a right bundle branch block pattern on the ECG. So these are very interesting concepts. It's not a all or nothing phenomenon where left bundle is blocked or conducts. It may be just slowly conducting, and the preferential conduction was via the right bundle previously, but now the right bundle is showing up abnormal conduction delay. So a very interesting case. Yeah, I think he needs an ICD, and with a previous left bundle branch block, now a prolonged PR and goes in the right bundle branch, I think it's fairly reasonable to proceed with a CRTD. Once you instrument this patient, you want to do it once and not upgrade the device subsequently because of its inevitable risk associated with an upgrade. Very interesting this case.
There is another very interesting question I can see on the chat. That's what's your opinion regarding usefulness of RA and LV pacing instead of CRT for financially constrained patients? That's very interesting, Tushar. You are trying to make it a poor man's biventricular pace or a CRT device, cardiac resynchronization therapy. Well, if the finances are constrained, why not give a his bundle pacing or a left bundle pacing with the dual chamber pacemaker? You know, that works actually much better than the RA-LV pacing. I would never recommend RA-LV pacing because I still feel that the sensing from the RV lead that we require, even when we are doing a fusion beat or we are pacing from the LV, that is a must, that is a requirement. You may have a RA-LV pacing, but you may result into a wider QRS because the depolarization of the LV is occurring from the epicardium to endocardium, and RV sensing is absolutely essential. So probably if the patient is financially constrained, I would put in either a his bundle pacing or a left bundle pacing rather than to do a RA-LV pacing. Dr. Ching, if you have different idea, please, I mean, if you differ in the thoughts.
No, I agree with you entirely. I am fearful of a RV-LV dual chamber pacemaker as a poor man CRT. I do agree with you. In addition to what you say, remember, ventricular depolarization is from endocardium to epicardium. That's normal ventricular depolarization. When we put an LV epicardial lead, is LV depolarization from epicardium to endocardium. In some individuals, such dispersion may be pro-arrhythmic, and hence it is wise to have a CRT-D, you know, if they fulfill criteria. So this just me, my position and my understanding of what in the literature in providing such therapies for this patient. I would avoid a dual chamber pacemaker RA to LV option.
Correct. There is a very interesting question which Jeremy has posted. He said, do we only use lead 2 to look at the notch that you mentioned? The notch which I mentioned here in the case was seen on lead 2, and when lead 2 represents the left side. You know, it is the left side activation which is represented by lead 2, and it is the scar in the left side or the left ventricle which was being which was there, which was a source of a slow area. That's why we concentrated on that to move it out of the QRS or at the distal end of the QRS, where it will not contribute to the contraction of the LV. So that is why we concentrated on that. It depends upon in which lead the notch is being seen. Here, the lead 2 was representing actually the scar in the left ventricle. That's why we concentrated on that. So,
okay, thank you. We still have a few minutes. Some of our participants, they asked about your comments about the HIS pacing. Do you have any comments about HIS and CRT?
Dr. Ching, you answer that question. I don't want to get into that controversy because I have discussed this thing a lot in many forums, but somehow, you know, we lack randomized control trials, and so we are still keeping our comments reserved. But please, you please go ahead, because you are doing a lot of this.
No, okay. This is a very topical question. Would His bundle pacing and deep septal pacing, which is to pace the left bundle branch or the septal region, be a suitable alternative to CRT? My personal feeling, I think it's very promising. I think it seems physiological, and I hope the results are good. And I do want to await randomized control trials to see the effects of His bundle pacing and or deep septal pacing versus CRT or traditional RV pacing. I really want to see randomized control trials and data to make a good conclusion. But I think it's promising. But I don't wish to jump. I don't wish to jump on the bandwagon and do all of it, thinking that assuming that it is promising. I remembered some time ago, just about when I was a fellow, there was a lot of interest in RVOT pacing too. Correct. It seems also fairly physiological, but the results were less than anticipated. So I'll wait for that. I will cautiously await results of RCT.
Right. I mean, very well
Over
said.
to you.
Yes. In fact, there are no RCTs available. None has been started even till date. There's data available for various centers, which are a good number of cases, but not randomized. And the results are very promising, as you said. I do agree with them. My feeling is that if I have to do it, I would do all my pacemakers with His bundle pacing. But when it comes to CRT, I would like to wait for more data to come out, before I can really say yes. I'm going for all patients in this.
All right.
All right. Thank you. Thank you very much for answering the questions from our audience. Due to the time, so we have to stop here now. And before we close, may I invite Professor Cheng to give closing remarks for today's webinar?
Thank you, Jeremy. I hope everyone has learned a little bit about ICDs and CRTs. And as I mentioned earlier on, it's not just the implantation techniques that we must be familiar with, but also the post-implantation techniques to optimize the CRT, to troubleshoot an ICD, to recognize how it behaves and how the device thinks on an ECG. So I want to thank the previous speakers, Dr. Daniel Chong, Dr. Aurora, for their wonderful talks. And I hope it will give you, or rather it would cause the attendees to have a greater interest in ECGs and EGMs and the peculiar therapies provided by ICDs and CRTs. And I want to thank Abbott for their collaboration and sponsorship for this wonderful program. And I believe that such collaboration and partnership will help improve awareness and as well as improve education and troubleshooting for patients who will benefit from such devices. Thank you. I wish everyone a good evening and a good weekend. Goodbye.
Thank you, Dr. Cheng. Nice talking to you.
Thank you.
Bye-bye.
Thank you,
Jeremy.
Cheng.
Thank you, Patrick.
Thank you, Dr. Aurora. Thank you, Dr. Chung, and of course, everyone for participating in this webinar. So I hope you stay safe and healthy. Thank you.
Thank you.